We'll be starting with the next session, clinical interpretation and expectations from our clinicians. Like as lab persons, like I'm a pathologist, what we expect from the clinicians and also vice versa. So now here today we have with us our esteemed panelists, Dr. S Doda, a very reputed radiologist, and he is director of Dr. Doda's Diagnostics and Healthcare, New Delhi. He has fellowships in CT, MR, and color Doppler from prestigious institutes from UK and USA. He has also been president of Indian Radiological and Imaging Association. Apart from this, he has organized several CMEs. He has even received Sir J.C. Bose Memorial Orator Award in 1999, which is the highest academic award in Indian radiology. Also, he has been honorary radiologist to the former President of India, His Excellency Shri Pranab Mukherjee. I would like to ask Dr. Doda. Dr. Doda is a leading radiologist in Delhi. Sir, how does imaging help in the detection of fluid collections in various parts of the body? And also, how do you differentiate between simple versus complex fluid collections on imaging?
Very good evening, ladies and gentlemen. Thank you very much to the organizing team of CAHO. So let me begin with, see, when we come to the various types of body fluids or fluid collections, we call it more often in the imaging. See, some of the basic things we have to keep in our mind, that imaging basically helps in locating these fluids precisely in the various body parts. We can assess the quantity of fluid collection. Like we all are aware that on the chest X-ray can show small quantity, moderate quantity, and large quantity. But if it is less than 200 cc, we cannot see it on chest X-ray. Whereas on ultrasound, we can see up to even 30, 40, 50 cc also. Then imaging also helps in predicting the consistency of the fluid, whether it is thin or thick. We call it particulate, and it can be even more complex in the sense that this could be hemorrhagic, this could be having pus content, multiple septa. The wall of the fluid collection where it is located could be very thick. I mean, this gives an idea for later on, aspiration of these fluids. One has to be prepared accordingly with the kind of needle which is required. Then the relationship of the fluid to the adjacent structures, because this helps in, finding out the etiology as to what could be the cause of this fluid. For example, there is a collection in the left flank of the abdomen, and we find on, let's say, on ultrasound or CT scan, that it is located next to the colon.
Yes, sir.
There are a few other divertically also, so we can certainly conclude that this could be a diverticular abscess. Similarly, there can be an aneurysm, and there is a collection nearby. We can understand that possibly there is a leak which has led to a bigger hematoma. I'll just show you that these are various types of fluid collections. You have a liver abscess here. You have a large pseudopancreatic cyst. And you can also see that there is bilateral psoas abscess with an additional collection in the parietes and the left lateral abdominal wall. And in the next slide, like for example, here you can see large necrotic nodes with some calcification over there, and the patient's not having any tenderness. So you can easily conclude that this is a cold abscess, which is due to tubercular conglomerated nodes. You can have a collection, let's say, around the anus, that this is a perianal abscess. And like there is a cystic fluid containing lesion in the muscle bundles, and with a small little calcific focus or a nodule on one side, and with a cystic area over there, you have practically no doubt that this is nothing but a beautiful picture of cysticercosis. So the fluid, as you asked just now, can be thin, can be thick. You can see that on the left side, you have a large fluid, large ascitic fluid in the abdomen, which is a little more black than probably this fluid, again ascites with having little particulate kind of material within. So we know that this is most likely a thick fluid, and of course you can aspirate these fluids for further evaluation. Ultrasound is a beautiful imaging modality. It is simple to perform. It is very dynamic because at the time when you are doing it, you can manipulate the things so much that you are able to see a lot more. For example, the chylous fluid typically has far more blackness on ultrasound than even a simple ascites. So thereby it gives an indication that there could be sort of, chylous origin of this ascites. And then I was talking about the particulate kind of fluid. This is most likely infected pleural effusion or going towards the empyema. My next slide clearly shows a sort of empyema in the pleural cavity with multiple septa within the fluid, which are shown so nicely on ultrasound. So these are variety of the fluid collections in the body, variety of imaging modalities, which can show these fluid, and they can also quantify these fluid collections. They can characterize these fluid collection. They can guide you for further evaluation. The MRI has a beautiful quality that by exploiting its certain parameters, the hemorrhage and its degradation products can be highlighted, and a specific information can be obtained as compared to ultrasound and CT. For example, you see that this collection in a case of endometriotic cyst is bright both on T1 and T2. So you have no doubt about it. This is lying next to the ovary, a thick-walled chronic collection, a sort of cyst having hemorrhagic fluid. So this is a chocolate cyst. So this is what I wanted to give you a glimpse of, what all we can see on imaging. Yeah.
Thank you, Dr. Doda. The query I had regarding the simple and complex fluid collections, how we see that radiologically, the images were very clear. Like even I could make out how we see a complex fluid, how we see a complex fluid collection on imaging. And Dr. Doda, I would like to ask you, anything one needs to take care about in imaging guided aspiration procedures?
See, one of the wonderful addition to doing the imaging in various fluid collections, in fact, in the evaluation of any disease entity, is that you are able to get the imaging guidance to collect the samples of the fluid collections, as well as go into the deeper aspect of these things. For example, the imaging helps in going to the right place. Sometimes these places are very, very deep in the body, and it is not possible to do that guesswork. Earlier, in our student times, we were able to aspirate the pleural effusion blindly, but nowadays nobody will do that. And not only that, we would aspirate maybe even a smaller quantity of fluid for the diagnostic use. And for that, we can utilize the ultrasound guidance. As I said, you can go deeper in the body. Like in this particular case, this is a case of CA gallbladder. You can see the gallbladder, and gallbladder contains obviously a lot of complex bile. And if you do aspiration without thinking much, you will only aspirate the bile. Whereas there are calculi here, there is a mass over here. And with the help of imaging, you are able to go precisely into the mass so as to get the most positive result in the form of cytopathology. So I remember, once I had gone 14 centimeter deep into a necrotic node next to the aorta in the chest, and we were able to take the sample with the help of a 15 centimeter needle on CT. So that is where the, wonderful use of imaging can be there, particularly ultrasound and CT. So that adds a lot to the evaluation of whether it is a fluid containing mass or the necrotic mass and so on. Yeah.
That's right. Also, Dr. Poranik, I would also like to ask you, like, as a clinician, what is your opinion about processing of a traumatic CSF in the lab? You often come across traumatic CSF.
I have already referred to this in my slide presentation, but I will speak out the salient points. Number one, the traumatic sample should not be discarded. Number two, it should be collected in at least 2 tubes or 3 tubes and see whether the RBC count is going down or not. If it is a uniformly hemorrhagic subarachnoid hemorrhage, the RBC count will be same in all the 3 test tubes. But in the case of a traumatic CSF, the density of blood in the first tube would be highest and will be lowest in the third tube. Number two, one of the tubes should be centrifuged immediately on the bedside or near the lab. And if it is a traumatic CSF, after the centrifugation, the blood will settle down while the supernatant would remain clear. If it was a prior subarachnoid hemorrhage which has occurred in the brain itself, in that case in the hemorrhagic CSF, the RBCs will settle down, but the supernatant would be xanthochromic or yellow in color because the RBCs have already been started the process of lysis. So the bilirubin has started getting liberated in the CSF. And the third was that even if you are suspecting meningitis or encephalitis and you want to know what is the cell count, what is the protein level, what is the glucose level, so they should still be tested. The cell count should be tested and you can make a correction for 1000 RBCs to 1 WBC. You can make a correction of protein as 1 milligram of protein rise for 100 for 1000 RBCs and a slight increase, about 20% of increase in the CSF sugar if it is blood mixed. So there are correction formulas or correction factors for cell count, for protein and for glucose. And of course, a traumatic CSF can still be sent for culture if you are suspecting a meningitis infective pathology.
Yes. Thank you, Dr. Poranik. Dr. Doda, I would like to ask you, like, what are your expectations from clinicians regarding these samples and all these various imaging modalities and investigations which are sent to you?
See, as a radiologist, I give maximum importance to the clinical picture of the patient. See, I would always like maximum clinical details from the clinicians. So, which is, little less often that we get a request, which is having all these things. The previous investigations, for example, lab investigations, should be highlighted. The previous imaging definitely should be sent along with patient in case something has been done. For example, there is a pelvic abscess, there is a pseudopancreatic cyst, and there is an empyema, or anything for that matter. If you know this was the collection, this was the quantity of collection, this was the size of the lesion earlier, and now we have to give more practical information that this has decreased in size, so the treatment is effective. If it has increased in size, obviously, then there is a need to alter the treatment. And most likely, provisional diagnosis. What is there in the mind of the ideal thing is that we should always call back the clinician and discuss the case. And I think that is something very, very useful from the patient's management point of view. And I would go to the extent that I would like to know from the clinicians that what is the likely plan of management in the future, and in what way we can contribute to that. And we have seen this, the most I have enjoyed in my professional life is the interaction with the clinicians, the discussion with the clinicians about a case. And that's how we work out a case. And that's, I think, very, very necessary. Thank you very much. Thank you.
How clinicians should choose the radiological modality which will assist in diagnosis and management? And is it depending on the site of the lesion or the patient's history? Like, should it be X-ray, ultrasound, CT scan, MRI, or whatever? Like,
see, I think most of the things are reasonably clear in the mind of the clinicians. For example, Dr. Puranik is sitting with me. I think he is very well aware that in case we are suspecting anything, including a fluid collection in the brain, preferably one should go for an MRI or perhaps a CT scan as the second choice rather than, anything. In the chest cases, probably it will be better to go for a chest X-ray, because chest X-ray is a very, very good reflector of everything in the chest. As a matter of fact, whatever we see on CT, we can go back and see everything on chest X-ray nicely. And perhaps a further elaboration, certainly CT of the chest should be useful. In abdomen, generally speaking, an ultrasound is such a simple and effective method of doing the things. And it's just not for only screening. A good ultrasoundologist probably can obviate the need of 70–80% CT scans of the abdomen. So I think that's where, this kind of imaging can be useful. Even in, let's say, soft tissue structures, let's say muscular areas or musculoskeletal joint areas where you're suspecting a palpable swelling, where you're suspecting a fluid collection, whether it is Baker's cyst or any abscess, an ultrasound is a wonderful modality to give information.
thank you, Dr. Doda.
I wanted to add a little bit because Dr. Nandini wanted to ask me to differentiate between the lung abscess and
exactly.
with an adjacent fluid collection and empyema.
Yes,
I would just add 1 or 2 lines in that, whenever you have a fluid collection which is organizing in the pleural cavity, and that's what we call it empyema, it usually have a medial convex border. We call it pregnant woman's profile. So you have a convexity pointing towards medially, whereas if there is a lung abscess which is continuing into the pleural fluid, you will usually find acute angles around that abscess, vis-a-vis periphery, that's the pleura. So that is the obtuse versus acute angle, sides between the intrapulmonary and extrapulmonary pathology. In extrapulmonary, this is obtuse, and intrapulmonary, this is acute.
Okay, thank you very much. Thank you.
Thank you, everyone.